Welcome to this HealthShare online spinal pain advisory clinic. The purpose of this presentation is to explore a number of factors surrounding spinal pain. What could be causing your pain, the possible impact it may have on your health and function, how you can manage these symptoms, and what treatment options are open to you based upon the latest research. Before we start, I would like to talk about Calaquina Syndrome. This is a serious but rare condition caused by compression of the nerves at the bottom of your back. These nerves control the bladder, bowels, and genitalia. If compressed, this leads to a sudden change in how your bladder, bowels, and genitals work due to the diminished ability for these nerves to repair. This compression needs to be alleviated immediately, and therefore immediate medical attention should be sought. The consequence of delay can be long-term, life-changing symptoms. On this next slide, we will explore what you need to know about Calaquina syndrome, the symptoms to look out for. Saddle anesthesia is a term used to describe a change in sensation related to the nerves within the Calaquina. If you feel a loss of sensation between your legs, numbness or tingling in and around your back passage or genitals, or you are unable to feel toilet paper when wiping or washing, then you have symptoms of saddle anesthesia. As well as changing sensation, Calaquina syndrome can lead to disturbance within your bladder function. If you are unable to pass water, you have a loss of sensation when you pass water, you're unable to hold or stop yourself from passing water, or unable to tell if your bladder is full, then you are presenting with bladder disturbance. Similarly, bowel disturbance can be felt, presenting as incontinence or the inability to stop a bowel movement, or loss of sensation when passing a bowel motion, not being able to tell the difference between passing wind or passing a motion. Finally, Calaquina syndrome can also affect the genitalia, leading to sexual problems. For example, in a male, you may be unable to achieve an erection or ejaculate, while females may pass water during sex or experience a loss of sensation during intercourse. A sudden change in these symptoms outlined, in conjunction with spinal pain, may well represent Calaquina syndrome, and immediate medical attention should be sought. Within the UK, this can be achieved by telephoning NHS 111 or attending your nearest accident and emergency department. Let's now talk through the anatomy of the spine. This is divided up into 5 areas. The neck at the top is made up of 7 vertebrae. Its primary role is to support the head and allow movement. Below this, the thoracic spine has 12 vertebrae and is where the ribs attach. Below this is the lumbar spine or lower back. There are 5 vertebrae here, with movement predominantly occurring to allow flexing and extending of the back, bending and straightening. The remaining vertebrae are fused and make up the sacrum and coccyx. The lack of movement at the sacrum and coccyx means that these are not areas that give us pain commonly. Placing spinal pain in context, particularly within the UK, we can see that a third of the adult population each year will experience lower back pain. 20% of those people will see their GP. 84% of us will have back pain at some time in our lives. Although what is interesting is that there is no direct evidence that there is a link between age and back pain. You are not more likely to get back pain as you age. Most people's experience of back pain is that the disability commonly improves rapidly in the first month, with continued improvements occurring slower over the next 3 months. With regard to neck pain, in any 1 year, 40% of the adult population will experience neck pain, with 70% of us experiencing symptoms in our lifetime. There is no direct link between neck pain and age, but we do see it as more common from our mid-40s onwards. Finally, on to the thoracic spine, or the mid-back area. This is an area which is much less common to experience pain in, with only 20% of us having it each year, and also only 20% of us will have pain in this area within our lifetime. It is, however, more common in children and teenagers, more common in females than males. For this next section of this presentation, we'll talk through some common spinal conditions. We do find that providing people with information on what could be causing their symptoms does tend to allay people's fears. This presentation also enables us to provide a more contemporary view on what causes these common spinal conditions. Something that is vital in both managing acute situations so that they do not reoccur, or indeed providing good quality long-term management for more persistent problems. Let's talk now about acute back pain. The first thing we should say here is that it is very common. Back pain can be felt anywhere from the neck down to the lower reaches of the spine into the buttocks. It commonly improves over a period of a few weeks to months. It's often termed as mechanical pain, which is to say that it arises from the structures within the spine concerned with producing movement, such as joints, bones, soft tissues, including muscles, tendons, and ligaments. Although back pain may start for a particular reason, for example after prolonged sitting or lifting, sometimes it will also simply start with no apparent reason. This is okay and should not be a cause of worry. This next slide outlines what people tell us about the way they feel when they have acute back pain, allowing you to draw parallels with your own current presentation. People will tell us that pain will often get worse or better dependent on the position or movement they are making. People typically feel that it is worse with movement, although we do know that avoiding movement altogether is not good, particularly in the long run. It can develop suddenly or gradually, as suggested previously, but it can also be associated with feeling stressed or run down. We know that pain affects our mood, and it is right to acknowledge these symptoms within the wider presentation of acute back pain. Sometimes acute back pain will become more long-standing or persistent. This invariably has nothing to do with the anatomy of the spine or the severity of the injury, but more commonly to do with other factors that block your route to recovery. For example, an underlying poor level of physical health will reduce your body's ability to physically recover. Without good underlying physical health, we have much less in the way of resilience to recover from such an event. The resilience of our mental health also can be a key feature in the speed in which we return to full physical ability. Pain associated with acute back pain can often lead us to panic and stress and anxiety reactions, which then lead to a perpetuation of the situation, perpetuation of pain, and a broadening of the worry and anxiety around the situation. It is often through acknowledging the effects of mental health on this type of presentation that enables people to move through this, replacing stress and panic for confidence, reassurance, and a greater feeling of mental well-being. You may now be starting to see how an episode of pain can affect the way we live our lives, and that in some instances the way we respond to that episode of pain can affect the way we recover. We should start to look now at our social interactions. We all know that spending time with friends and family is an important part of our lives and makes us feel good. And therefore, it's not too much of a leap to suggest that if this was taken away from us by poor physical or mental health, that this would have in turn a negative impact on the situation. We see a reduction of social interaction as being something that has a negative effect on persistent pain, with a return to normal social contact being a difficult hurdle for some people to make. Similarly, there can be issues around work related to worries about return to work, or indeed a feeling that one has to continue with work despite pain due to financial issues. This slide really explains the complexity of pain when it becomes more persistent. Managing this does not necessarily have to be complicated. It simply means that we have to be aware of all of these factors, acknowledge their presence, and try to do something positive to improve all aspects. We're now going to move on to some different presentations, although we should continue to bear in mind that slide regarding persistent pain, as the effects of pain as it continues is the same whether you have sciatica or whiplash. So that brings us on to our next topic, which is indeed sciatica. This is pain arising from the nerve within your leg. Sciatica is commonly described as being shooting or burning in nature, and you may also experience symptoms of pins and needles or numbness. What is sometimes reported to me in clinic is that a shooting or burning sensation, for example within the buttock, will be termed as sciatica by a patient, and although this is a perfectly legitimate term for that particular patient to use if that is their understanding, really when we are talking about sciatica we are talking about pain mostly within the leg. For example, the pain is felt worse within the leg than the back. Even though people with sciatica do often have back pain, they will very much say the pain is worse within the leg. For example, predominantly to the calf or the outside area of the foot. Symptoms of sciatica will often be worse on bending or sitting, and they can be really quite severe in nature, causing significant pain. Although it is quite common to feel your leg with sciatica is not as able to achieve its normal physical abilities, if you start to feel that you lose strength in your leg, for example, as you walk your foot starts to flop onto the ground, then this is something that you should tell a medical professional about. So we now move on to our next topic, whiplash. Whiplash is something that most often occurs following a traffic accident, a slip or a fall. Most common symptoms include neck pain. This can be felt within the neck, the base of the head, or across the shoulders. The neck will often become stiff, with pain sometimes referring into the head, or indeed sometimes down the arms. Although whiplash does indeed often happen following an accident, it can take several hours after the accident for symptoms to occur. It is not uncommon for people to leave the site of an accident and then develop symptoms in the following hours. The key messages with regard to what to do following a whiplash is to manage your pain with painkillers such as paracetamol and ibuprofen. If these are indeed drugs that you are able to take. If there is any doubt, read the patient information leaflet enclosed or seek the help of a medical professional. Similarly, it is important to try to continue on with your normal daily activities as best as you can. Although these may hurt, it will speed up your recovery. Conversely, avoiding prolonged periods of rest for the neck is a good idea, and the use of neck collar or brace, although may feel good at the time, will certainly be detrimental in the long run. Next we come to brachialgia, or rather neck and arm pain. This probably should be seen as similar to sciatica, in so much as the pain in your arm is coming from the nerves within your arm. It's commonly described as shooting or burning in nature, which is also similar to that of sciatica. And mainly the pain is felt within the arm. So although somebody will have neck pain, the pain will be focused within the arm, often more intense in this location. Both sciatica and brachialgia both suffer from the overuse of common terms that do not help our understanding of the presentation. I'm sure you'll have heard of terms such as trapped nerves, nerve compression, or a bulging disc in relation to nerve pain within the leg or arm. However, this is simply not the case in most situations. Commonly, there is no physical nerve compression visible when we scan the neck or back in these situations, and the nerve pain is most likely related to an increased nerve sensitivity or chemical irritation. The reason why these terms are particularly difficult in the treatment of sciatica and brachialgia is that it tends to suggest that nerves need to be untrapped or uncompressed, or bulging discs need to be changed in some way, and this is simply not the case. In some instances, the nerve can be physically affected, and this can lead to sensations of weakness in the arm or leg. Clinically, we do see this as something that potentially indicates nerve compression and is more likely to move us towards imaging or scanning of the back or neck. We now move on to our next topic, that of spinal stenosis. This is an issue more common in people over the age of 60. Like sciatica, spinal stenosis will give us leg pain. However, its characteristics are quite different, whereas a sciatica will be particularly painful on bending or sitting. A spinal stenosis presentation will be one that actually is made significantly better by bending or sitting. The reason why spinal stenosis occurs over the age of 60 is that it is due to an anomaly in the way that the body ages. The spine changes with age, and the spaces for the nerves in your back become a little narrower. Similarly, those spaces are narrowed further when we stand upright, and they are opened when we sit or bend forward. This causes pain to arise in the legs that is provoked on walking or standing and eased with sitting. As well as pain, one can experience feelings of numbness, pins and needles, or even weakness. However, this is a presentation that is very positional. It is not uncommon to find a patient who can ride 10 miles on a push bike but struggles to walk 100 yards down the road. We now move on to the final condition to be discussed in this presentation. This is another presentation that has a number of different names, that of spondylosis, degeneration, or osteoarthritis of the spine. And really, these are just the same presentation with a different label. Although these labels sound medical in nature, really they are less medical and more simply part of a normal aging process. We can term these as grey hair changes. They are simply the byproduct of a life of wear, tear and repair during our normal activities. Interestingly, even in people in their 20s, MRI scanning will show us features of aging within the spine. And what we also know is that when we see features of aging within the spine, there is very little in the way of relation with the amount of aging seen and the level of pain a person may feel, or indeed if they feel any pain at all. When we talk about age-related change within the spine, we're talking about features such as degenerative discs, disc bulges, slips, extrusions, protrusions, and sometimes misalignment of the spine or spondylolistheses. These are all medical complex terms used to describe normal features of aging. And although we see all of these changes in the presence of spinal pain, we will also see them in people with no pain at all. You may be wondering how this relates to how you are feeling at the moment. On this slide, we have outlined some of the common descriptions that people tell us about their issue, so that you can compare these with your own presentation. The most common description used is that of pain and stiffness. We know that people will experience sleep disturbance, difficulty driving. People with neck pain will struggle with turning their head. It is common that people with back and neck pain will struggle with bending, lifting and carrying. People struggle with walking, caring for a partner or a dependent. And above all, spinal pain will make it difficult for people to continue doing the things that they enjoy. When we look at people with spinal pain, we see reduced spinal movement. For example, an inability to touch one's toes. We see tenderness to the spine, reduced sensation in the skin, reduced strength of muscles, altered reflexes, and painful nerves. So we now move on to how should you be managed with spinal pain. And invariably the question that often comes from patients at this point is, do I need an x-ray? And I think it is right to ask this question, as people are often experiencing quite significant pain. However, there is a clear answer to this question, and outside of spinal pain arising after significant trauma, so following a significant fall or injury, the answer to this question is no. X-ray will show us fracture, but it really will not show us much more detail that is of any use when it comes to diagnosing spinal pain. Then there's the question of, do we need an MRI scan? Now, MRI scan shows us a lot more in the way of anatomy in the spine. So in some situations it does have a use. However, we do need to be careful that when we organise a scan, we're going to let the outcome of the scan affect our treatment. And what we know is that in the vast majority of mechanical back and neck pain, or indeed mechanical back or neck pain with no loss of arm or leg function or weakness, it really does not change what we do in these situations, and therefore imaging is not required. However, there are certain situations where MRI scanning is important. We talked at the beginning of this presentation about Calaquina Syndrome, and when people have symptoms of Calaquina Syndrome, they require immediate MRI scan. Similarly, if people have symptoms of sciatica in both legs, or they have developed foot drop, this can be an indicator of more significant issues within the spine, requiring MRI scan. Similarly, severe leg or arm pain with significant weakness, particularly that which has not responded to treatment, should really have an MRI scan to help plan further treatment. In some situations, in the presentation of new back pain in conjunction with a past medical history of cancer, MRI scan is seen to be required. One of the key reasons why imaging of a spine is of little clinical value when it comes to deciding treatment for people with mechanical spinal pain is that it is not uncommon for imaging of a painful back to look very similar to that of a non-painful back. The table on the right of this slide came from a piece of research where they did MRI scans on people without spinal pain. The table shows their age at the top of the table, and then the findings that the MRI scan showed to the left of the table. The percentages within the table show the amount of people in that particular age group that had those particular image findings. When we talk to patients, they often worry about things such as disc bulges or wear and tear changes such as disc degeneration. What this table shows is that even at the age of 20, 3 out of 10 people that we would see would have a disc bulge anyway, even without pain. And by the age of 40, you are just as likely to have a disc bulge as not, with 50% of this age group having one. This then begs the question that if you can have a disc bulge and have no pain, why is it of any relevance to the pain that you are feeling now? And the answer to that question is it probably does not have any relevance at all. When the use of imaging becomes particularly interesting is that what we do tend to find is that when people are presented with an array of different complicated findings on MRI scan, most of which we know are likely to be there simply because they are, like everybody, aging, they often worry more about their spine in the long run. And we see that people with MRI scans that have been poorly explained to them often have ongoing symptoms, and their longer term outcomes are not as good. The key things that MRI scans cannot see, pain, muscle spasm, stiffness, these are the things that patients tell us they struggle with, and they are the things that we can try to affect with treatment. And it is for this reason that often physical examination and listening to people is of far more value than imaging alone. This does bring us nicely onto the treatment and management of spinal pain. The initial management of most of these conditions does not really differ. The key aspect to management should be that of education, helping people understand the situation they find themselves in is an important part of helping them manage this themselves. I hope that the preceding slides have given you some insight into what could be causing your symptoms. The second important point is the management of your symptoms. and using activity to modify your symptoms. It is often important during a bout of symptoms to walk the tightrope between doing enough but not too much. It is important not to stop all activity, but continuing on with activity that just aggravates and leaves you worse off is of no real value in the way that it will not lead you to improvement. The use of appropriate pain relief, as previously discussed, is incredibly important, as this enables you to continue on with your normal activities as best you can, but also undertake appropriate exercise. People often worry about taking pain relief only masking issues, but this is not something that you should worry about. I often use the analogy of pain relief reducing the volume on a music track. It does not stop the track from playing, it simply reduces the volume so that it is less loud. You will still hear the ups and downs of the track. For example, if you're doing too much with your back will still tell you, but it may allow you to continue on doing lower level things with less in the way of disturbance. Physiotherapy can be an important part of the management of spinal pain. Exercises are an important way of reducing stiffness and muscle spasm. Exercises themselves can often be pain relieving in their nature, and even if they are not reducing pain at the time, they are certainly reducing the accumulation of stiffness or reducing physical deconditioning. There can be a place for manual therapy within the treatment of spinal pain, often better used in conjunction with exercise. Over the short and long term management of the spine, it is important to think about maintaining your joint health. We've talked a little in this presentation about grey hair changes, the way our body adapts with age. One of the things that occurs as your body ages is its underlying resilience tends to reduce, which means that without maintaining a level of physical activity regularly, your body becomes less able to cope with the ups and downs of life, and therefore maintaining, improving and restoring your physical health becomes a key part of managing any acute or chronic presentation of spinal pain. For most people, the 5 key aspects outlined on this slide are as much as is required for the management of their spinal pain. However, for some people, more intense input is required. Often one has to deal with more longer term issues such as reducing body weight, stopping smoking, improving sleep, and working on emotional well-being become key aspects to the management of a presentation of spinal pain. Over the last few years, the NHS has started to roll out what is called the National Back Pain Pathway. This is a set of guidelines for how to treat people with spinal pain. This is based upon a rigorous review of all available evidence, and its recommendations really are the best that can be done at this point. We are, of course, aware that running alongside this type of national guidance, there are lots of experts on the internet. There are people who have had other treatments, manipulations, electrical treatments, injections, all of which can tell you that they have had great outcomes. And for lots of people, it can seem that the treatments on offer constitute a real minefield. It's this type of situation that produces a common issue that we see in clinical practice, that of when people aren't getting better, it's because they feel that they haven't had the right treatment, as opposed to the fact that time has to take its course, or that there are simply some complexities to their life that requires a little bit more input to iron out. The aim of the National Back Pain Pathway is to ensure that all NHS clinicians working along the same pathway to reduce this complexity and confusion for patients. By watching this presentation and heeding its advice, you are at the top of this inverted pyramid. We're providing good quality initial advice on self-management, and for most people this is all that is required for people to make a full recovery. Some people do require a little bit more input. We talked on the slide previously about persistent spinal pain, about the way that emotional health, social interaction and work-related issues can start to play out a factor in how people recover. And for some people, input related to these factors is required. That, in conjunction with the good quality initial self-management advice, is enough to make the vast majority of people reach a full recovery. Following on from this, recommendations take us down the pyramid. An assessment by a spinal practitioner, which could be a physiotherapist, may become involved for those people that don't reach full recovery. Their role in this situation is to evaluate the need for different types of treatment or investigation. Similarly, they may organise physiotherapy, including exercise or manual therapy, or indeed more combined physical and psychological treatments. It is then at that point that we start to contemplate whether surgery for people with leg or arm pain is required. However, this is a minority of people. The vast majority of people require no such intervention. You may have read some of the articles on this slide. The article in the Sun newspaper to the left was reporting upon a study in the Lancet Journal looking at how effective repeated injections into the spine were for people with long-standing pain. They found very clearly that this repeated quick fix management style was of no value to patients and cost the NHS considerable amounts of money. They advocated the management of more persistent spinal pain to mirror the national back pain pathway as previously discussed. The article in The Guardian on the right-hand side of this page talks much less about managing pain when it arises, rather more about preventing back pain. This outlines the fact that the best way to avoid having spinal pain is to maintain a fit and active lifestyle, something which is music to our ears. There is mounting evidence that the best thing you can do is keep yourself fit and active, and this will reduce your likelihood of back pain. This article outlines that there used to be a collective wisdom about what were good postures or bad postures, when really research now tells us that it is physical health that is more important. Managing positions as opposed to managing people's physical health is a poor way of dealing with persistent pain. If bending is something that you are able to do, you are strong, fit and active, there is absolutely nothing wrong with bending. However, fearing bending because you feel that it is something that is bad will make you not very good at this, and mean that actually the next time you bend over you are going to be less prepared for it. So let's recap over some of the helpful hints and tips that we have been through on this presentation. We have talked about activity modification and pacing of activities. Try to modify your tasks to reduce the amount of pain that they provoke. For example, if this means moving your monitor at work so that you do not have to twist your head quite so much, this would be a good thing to do. Similarly, if bending over is particularly painful, make sure that you do this gently in a controlled fashion, and make sure that you do not have to reach forward to pick up whatever it is that you are reaching for. During an acute flare-up of spinal pain, combined movements such as bending and twisting are likely to be more provocative, and these are things that you could try to change. Taking relative rest is important. That's not to say doing nothing, but simply reducing the load on your spine by avoiding prolonged activity. However, do not completely avoid moving the spine, as this will have a longer term a detrimental effect. Often people struggle with a position during sleep. If you have one-sided neck pain or back pain, it is quite common for it to be painful to lay on that side. So propping yourself up with pillows, maybe in a quarter turn, so that you are laying on the other side, but supported so that you don't roll over onto your painful side at night, would be of benefit. The application of heat or ice can be of benefit with regard to pain relief. Really, it does not matter so much which one you use after the first 48 hours. Simply use whatever helps. Do not apply either heat or ice for longer than 15 minutes, and make sure that you protect your skin by applying a protective barrier such as a small towel. We have discussed on a couple of occasions the use of analgesia to help relieve symptoms. Taking painkillers regularly is usually more effective than just taking them when required. This helps them build up in your system and gives you a smoother level of pain relief rather than riding a roller coaster of pain while trying to continue on with your daily tasks. If you are not taking any pain relief and you feel that you may need it, first place to inquire about this would be with your pharmacist. They will be able to give you advice on over-the-counter medication. If this is of no help, then you should then discuss other medications with your GP. There are a number of lifestyle choices that are important when managing more persistent or even acute spinal pain. We know that smoking is linked to the delay of healing, gives us poor tendon health, and can often lead to joint pain. So stopping or reducing the amount that you smoke will help your spinal problem and help your pain. There is a link on this presentation to advice on how to stop smoking. Similarly, weight loss plays an important part. We know that the benefits of weight loss is not simply down to reducing the amount of load that we place through our joints. We know that the fat cells that we have within our body do not act just as storage. They are an active part of your body, and they affect the amount of inflammation that we have. We know that fat cells can circulate around the body, causing inflammation and influencing joint health. I've talked quite a bit during this presentation about physical activity levels and the need to maintain a physical active life to enable you to cope with the rigors of your daily routines. I've also talked about using activity to build up resilience so that you're able to cope with more excessive activity and therefore less likely to fall into a position of having pain. So what does this look like? Well, the government advice on staying active is that we should be trying to undertake approximately 75 minutes of vigorous activity per week. So this is activity that makes it difficult to talk while undertaking whatever it is that you are doing. This could be a run or sport or stair climbing. Or we should be doing 150 minutes of moderate activity, such as walking, cycling or swimming. This type of activity might alter your breathing, but you would still be able to talk. In addition to this, there is advice that we should be trying to build up our strength on a couple of days per week. This may be dancing or Tai Chi, undertaking bowls, yoga, or going to the gym. We know that undertaking this type of activity directly reduces your chance of having joint or back pain by 25%. However, it also reduces your chance of type 2 diabetes by 40%, by 35% reduction in cardiovascular disease, and reduces your chance of breast or colon cancer by 20%. However, for lots of people, undertaking physical activity just makes you smile and lifts your mood. The final bit of advice that I wish to give is be patient with yourself. Know that everyone's journey to recovery will look slightly different. It might take a little bit of time to start to see improvement in your symptoms. And even as you improve, it is normal to see your symptoms vary from day to day. You may think that you're improving and then have a bad day. This is okay. Your symptoms will be affected by lots of different factors. It is important to see the bigger picture. Start small and gradually build up activity, because small changes can make a big difference. On the same web page that this video is embedded are a set of exercises to be done for either the neck, mid-back or lower back. These are a great place to start when it comes to incorporating exercise into the management of your spinal pain. The next few slides are going to outline some great advice on how to use these exercises. The first point I wish to make is that everybody is different. Some exercises will work for you, whilst others might not. Just do more of what makes you feel good. First of all, you need to start by finding a baseline of what you can currently do, and then gradually try and build up from that point. It is better to spend a bit of time doing exercises thinking these are a bit easy than doing some really hard exercises and making everything hurt more to begin with. This will only start you off on a bad footing. So find your baseline and then work from there. Little and often is often better to begin with, especially if your spine is really sore. As the exercises get harder, you can reduce the frequency of the exercises to allow you more time to recover. So, for example, doing them twice a day when the exercises are harder, rather than doing them 3 to 4 times a day when they were easier. You can also use the traffic light system to help you guide the intensity and frequency of which you exercise. So, the traffic light system tries to answer the question of, should exercises be painful? The broad answer to that question is that it doesn't matter if they are a little painful. However, I now will expand upon that. We try to think about 3 different zones of exercise. So if we think about pain on a scale of 0 to 10, if when you are exercising your pain is between 0 and 3 out of 10, and your pain settles quickly or immediately after exercise, you're in the green zone. If your pain is 4 to 5 out of 10, and settles within a few hours of activity, you're in the amber zone, and this is still acceptable to exercise in this area. However, if your pain is 6 out of 10 or more, and the pain stays elevated for more than a few hours or even lasts into the next day after you have exercised, you are just doing too much. It might be worthwhile to begin with trying to exercise in the green zone and then slowly trying to move into the amber zone as you start to feel easier. Or if you think that the green zone is too easy for you, push into the amber zone. You can always back off if required. So that really outlines good quality initial management of spinal pain. I do at this point want to answer a few questions that we commonly get asked. That is, do I need injections or do I need surgery? There is very clear guidance on these questions. In the case of central neck or back pain, spinal injections are not recommended by NHS England because they have been shown by research to simply not work. In the case of sciatica or brachial G, in severe pain, when conservative treatments such as exercise and pain relief have not helped, then spinal injections can be considered. Generally speaking, spinal surgery is rarely required for spinal pain. There are some instances of significant arm or leg pain in conjunction with weakness, whereby spinal surgery may well be of benefit, or in situations where people are at risk of developing Calaquina Syndrome. However, the time to be making decisions about injection or surgery is very much after a period of conservative treatment as outlined in this presentation. The only caveat to that position is for people who develop symptoms of or become at risk of Calaquina Syndrome, whereby surgery is required to be undertaken immediately. Finally, some practical questions that commonly get asked. What activities can I do and how should I adapt them? Well, despite pain on movement or even movement restriction, it is not dangerous to move your spine. It is unlikely to cause you damage or harm. You must keep moving, participate in normal leisure activities where able, and work where possible. Remember to modify your activity if it is painful. Do more of your pain-free activities. And then also do less of your painful activities. So, in summary, spinal pain is a very common problem. Most spinal pain will improve with time if it is managed appropriately. In the meantime, it may help to modify your activities and take pain relief. Exercise will also help your spinal pain to get better. It is good to remain active while you wait for your spine to improve. Lastly, thank you very much for listening to this spinal joint pain advisory clinic presentation. I really do hope you found it of use. If your back or neck pain does not improve as expected, then you can fill out an online self-referral form found on the HealthShare website. Thanks for listening.